Good afternoon, colleagues. I hope you can all hear me. I'm loud and clear. Nelson, we are good? Hello, Nelson, you can hear me on your side? Okay, thank you. So good afternoon, everyone. Good afternoon, colleagues from far and wide. I'd like to take this opportunity to welcome you to our webinar session this afternoon. My name is Dr. Carol Okoth. I'm a physician. This webinar we are actually hosting to mark the Spinal Cord Injury Awareness Day. So I really appreciate your attendance. During this session, we'll take you through spinal cord injury, the journey of a spinal cord injury client in Kenya, from the point where they are diagnosed with a spinal cord injury up to the point where they go to rehab and finally reintegrated back in the community. So I hope that this session will be informative. It will give us insights. It will provide us with the opportunities, where we can collaborate and get to interact with each other later. I know we have people from the counties also joining us. And for this session, we have a team from the Kenyatta National Hospital and a team from the National Spinal Injury Referral Hospital who will be presenting in collaboration. So I know it's very interesting to have two level 6 or two referral hospitals collaborating, but I'm hoping that at the end of the session, you will see why we work together. And yeah, I take this opportunity to welcome you. So as I've mentioned, we have a team both from the Kenyatta National Hospital and National Spinal Injury Referral Hospital. We have Dr. Agatha, Dr. Carol, myself, Wallace Mburu, Miriam Mwathe, Mr. Masinde from the National Spinal Injury Referral Hospital. And from Kenyatta National Hospital, we have Joseph Colley, Evans Okongo, Paul Elijah, and Mickey Baron. So I'll take this opportunity and welcome Dr. Olago, who will take us through the introductory session. Then we'll have the team from Kenyatta National Hospital, and then the team from the National Spinal Injury Hospital. And after the presentations, we'll open it to the panelists. So thank you very much, and karibu, Dr. Olago.
Good afternoon, everyone. I'm glad to be here. Thank you very much, Carol, for the introductions. Dr. Agatha Olago, as Carol has introduced me, I'm a physician at the National Spinal Injury Referral Hospital, and I'll be talking about giving us an introduction to spinal cord injury. Okay, so just an outline of my presentation. We'll go through the definition of spinal cord injury, the causes of traumatic spinal cord injury. We'll mainly be focusing on traumatic spinal cord injury, a bit about the epidemiology globally and especially in our locality, complications from spinal cord injury, treatment, impact, the cost of caring for clients with spinal cord injury, and not just the end, but I'll be touching a bit on the challenges that clients with spinal cord injury face. So just in definition of this is an acute traumatic lesion of neural elements in the spinal canal, that's the spinal cord and cauda equina, which results in temporary or permanent sensory deficit, motor deficit, or bladder or bowel dysfunction. And the signs and symptoms really depend on the injury severity, the location of the injury, especially on the spinal column, whether it's cervical, thoracic, or lumbar. And we know that people with spinal cord injury can experience either partial or complete loss of the sensation of sensory function or motor functions. And this even includes the respiratory motor muscle function. Right? They can also have bowel, bladder, and sexual dysfunction. And we can also have dysregulation of the blood pressure, heart rate, and or body temperature. These are all functions of the spinal cord. We know that the spinal cord is what allows the brain to communicate with the muscles, with the rest of the body. So any injury at any point of the spinal cord can actually cause any of these symptoms. So for how we classify spinal cord injury, especially it depends on the level of the injury. So for example, now we have the spinal cord injury. So we can have the paresis where there's weakness. So in this case, that's an incomplete spinal cord injury. And if it's plegia, that means that there is actually total loss of motor function. So we have paraplegia, and that means below the level of the injury, there'll be complete loss of the muscle functions, especially. Where we have the quadri or tetraplegia, we can have the quadriparesis, whereas that means an incomplete injury below the level of that injury. And for quadriplegia, where you have total loss of function before the level of that injury. So you can either have paraparesis or paraplegia, or quadriparesis or quadriplegia, depending on the level of the injury. So for quadriparesis or quadriplegia, it's usually at the cervical level, because anything below the neck, most of these are controlled by functions which are at the cervical level. So this can help you to remember at least some of the levels of injury for the spinal cord lesions. So in terms of spinal cord injury, we know that traumatic spinal cord injury is actually more than 90% of the cases actually traumatic, but you can also have some causes of non-traumatic. So for example, when it comes to traumatic, most of them actually come from the vehicle accidents. By vehicular accidents can be anything transport related, especially motor vehicle, motorcycles. We also have injuries from assault, falls from a height, and even sports injuries, especially in the young children, adolescents, especially, for example, like from swimming. The ones who fall, like diving into a shallow pool, we know that this can cause sports injuries, rugby, football sometimes, but we know that these are causes of the traumatic spinal cord injury. We also have non-traumatic, which can result from congenital lesions in some cases, infections such as spinal tuberculosis, which is common in our area. We have malignancies, which can result in this. These malignancies can either be within the spinal cord or even around the spinal cord and compress the spinal cord in this case. And we also have degenerative spine lesions. And we know that spinal cord injury leads to a lifelong physical disability. And this results in a lot of increase in the incidence of non-communicable diseases, cardiovascular diseases. There's also high mental health challenges. There's a high incidence of mortality. Forgive us some of the ×2 or ×5. I'll correct that later when I bring out the epidemiology of this. Personal, societal, and national health costs, because most of these are actually young people, as we'll see in the epidemiology. And there are worse outcomes, especially in our area. In our low and middle income countries, we have worse outcomes, especially because of our response. I think we'll be discussing quite a bit about that today. There's also reduction in the quality of life, the socioeconomic opportunities, education, and employment opportunities. We have some legislation regarding spinal cord injury and spinal health in general. Some of the international ones within, for example, the UN Health Declaration, we have the Sustainable Development Goals, the UHC agenda, which mainly really focuses on leaving no one behind, Rehabilitation 2030 and World Rehabilitation Alliance policies. We have the African Union Agenda, the AU 2063, and we also have the East African Community Agenda 2050. As a country, we have the Constitution of Kenya, which gives a right to health for all Kenyans, all people within the country. We have the Disability Act, the Vision 2030, and the bottom-up economic transformation agenda. So we need this all comes to the point of ensuring that you have a right to quality healthcare in terms of health promotion, preventive services, treatment services, and rehabilitation services. So when you talk about spinal cord injury, it really comes in at the center of this, ensuring that you have a right to quality healthcare. In terms of epidemiology, the WHO gives us an incidence of about 40 to 80 cases per million population, and 90% of these being traumatic. And you know that globally we have almost over 15 million people living with spinal cord injury. And in our regions, especially the low and middle income countries, we know that the cases are at least 130 cases per million. And this is about 1.6 times higher than the higher income countries. So we know that it's a major cause. Spinal cord injury is a major cause of long-term disability and accounts for over 4.5 million years of life lived with disability. This was data from 2021. And there's a male and youth predominance, and it has a very high morbidity and mortality. So the studies which have been done in our region, and there's a systematic review carried out in the area in Africa, and it showed that we had at least 13.6 new cases per 100,000 persons. But one thing that was noted is that these cases are really underestimated, and there may be more. Tanzania's studies from Tanzania show at least 26 cases per million. South Africa had quite a varying number, but it shows that in the urban areas, it could go up to 75 cases per million, with males comprising at least 72% of these. And most of these injuries were secondary to road traffic accidents, falls, as well as assaults and injuries at 28%. And this review actually covered at least over 1,000 clients. In Kenya, we're estimating that you may have about 7,980 new spinal cord injury cases per year. So we know that we're missing out quite a number of clients with spinal cord injury. And we know that our data may not really be accurate. A study done in Kenyatta National Hospital around 2014 by Kinyanjui and Mulimba showed that the average age of patients with spinal cord injury was about 37.6 years. More males. This one gave a very high prevalence of the males with a ratio of about 15:1. And most of these were from road traffic accidents. But what it really brought out was that the outcomes at 3 months were really poor, with high mortality rate, about 40% mortality rate at 3 months. And almost half of them developed pressure sores. And these were mainly in patients who had cervical injuries. Although the number was small, but we know that it actually reflects in a lot of the clients that we actually get to see. A study done from data in, a retrospective study done from data in Spinal Injury Hospital between 2010 and 2014 showed the average age being similar, about at 7.6 years. And most of them were actually young patients, 30 to 39 years being at 28%, 18 to 29 years old being at 27%. But the male to female ratio here was a bit higher, 2:1. And the main cause of this were transportation related. We hope that you can actually end up having more studies with this improved collaboration between Kenyatta and National Spinal Injury Hospital and the rest of the country as well. In terms of complication from a spinal cord injury, we've talked about what can happen acutely. We know that we can have complications related to the accidents. So most of them will end up with those acute complications resulting from shock, the injuries from the spinal cord injury itself, brain injury, the head injury. We can also have a lot of the injuries to the vessels, internal injury as well. But you know that secondary complications from a spinal cord injury also provide contribution to the mortality. And they range from neuropsychiatric disorders, the chronic pain, loss of bladder function, loss of bowel function, We have lots of sexual function as well as lots of motor function. So one of the main complications that we get are usually the pressure sores, and this is mainly contributed to by the impaired skin sensation, as well as the fact that the lack of mobility. And this is especially higher in those patients with the higher injuries, the cervical injuries, who cannot move themselves. There's also a lot of issues to do with weight loss or gain due to muscle atrophy and decreased bone density. And the weight loss or gain also contributes to cardiovascular diseases as well. We have osteoporosis due to bones breaking down more than the rates that they're usually forming. Edema or leg swelling due to poor blood circulation due to lack of physical activity, depression and anxiety. We mentioned those neuropsychiatric disorders. There's quite a number of patients who are on admission to rehabilitation centers actually reflect this depression. Sleep problems due to the body temperature dysregulation, the pain, especially chronic pain, neuropathic pain, even just phantom limb pain as well as also medication side effects. They mostly also have a bloated stomach due to the impaired diaphragm or dysfunction of bladder and bowel. And this also causes a lot of constipation as well. Bowel or bladder dysfunction. This is mainly because of the spinal cord injury, causing to disruption of signals to the muscles of the bladder and bowel. They easily have a lot of contractures, especially when physiotherapy is not started in the acute stage. And this also leads to a lot of heterotopic ossification. We talked about the osteoporosis and a lot of bone, losing a lot of their bone mineralization as well. We also have high rates of infection due to pneumonia, especially when they're positioned badly or even with the higher cervical injuries. And we also have a lot of urinary tract infection. Especially these patients have to be catheterized a lot of the time. The instrumentation leads to infections and they easily develop the infections, UTIs leading to sepsis. They can also get complications such as autonomic dysreflexia, which is one of the main one of the emergencies that have to be handled as soon as possible, as soon as it's diagnosed, and can lead to even death in patients with spinal cord injury. In terms of treatment of spinal cord injury, a lot of this is mainly supportive, especially in our setting where we're not doing using a lot of the modern modalities of treatment. But one thing to note is that it requires a multidisciplinary approach. And this needs to start as early as the field, trying to prevent shock, trying to prevent, ensuring that there's no hypoxia, as to minimize especially injury to the spinal cord. For example, in the field, we need to ensure, and in the hospital, we need to ensure that we mobilize the spine, ensure that our clients have access to good pre-hospital care, and ensure that the spine is cleared before having other investigations and management. We need to ensure that you have a neurological exam. This should happen especially within the first 72 years. And we're really urging that we use the ASIA, the American Spinal Injury Association system for conducting that exam. And this can really help us to even just determine prognosis and even just determine how the patient should be managed following this. Imaging, especially ensuring that you have high quality CT scans. This can really ensure that appropriate care is taken. Early surgery is usually indicated, especially the first 24 hours, but we know that this is a challenge in our setting where the costs and other challenges of getting the patient to the right institution delays care. But we really add that clients with spinal cord injury are transferred to appropriate centers as soon as possible. Most of this will usually be level 6 facilities. but early surgery has been found to be beneficial to decompress and stabilize the spine. No neuroprotective treatment has yet been found to improve outcomes. So steroids are currently not indicated, especially they've not been, all the studies done so far have not been found to improve outcomes of the spinal injury, degree of the spinal injury. But you know that there's future hope of functional improvement, especially with the neurodegenerative strategies. For example, the stem cell transplant, but these are still investigational and have not been especially in our region. So these are still, it may give future hope, especially to clients with spinal cord injury. This is just a chart showing the Asia, this is the Asia chart that allows us to classify clients with spinal cord injury. It looks at the motor function. It looks at these 10 groups of muscle, of motor, the key muscle groups, and is able to tell whether it will be able to determine the level of injury the patient has. It also looks at the sensory sensation. So a combination of the motor and sensation is able to give us especially the degree of impairment, the neurological impairment that the patient has at the beginning. So it's really key to use this, especially in determining the neurological impairment, and it really helps for the rehabilitation of the clients. In terms of prognosis, I mentioned that this, I brought up the Asia scale specifically because this can actually help in prognosticating the patient. The level of injury, of course, the cervical injuries have a poorer prognosis, and even how the cord looks like on MRI especially, but so this can help to determine how the patient will progress following that. We know that the mortality is highest usually in the first 24 hours, but we know that mortality also increases in the first 6 to 12 months after spinal cord injury. And the main causes are usually the secondary complications we talked about. Respiratory failure, pulmonary embolism, cardiovascular disease, and sepsis. And we know that we have high mortality, especially in the elderly, the ones with the high cervical lesions. That's C2 to 4. And also severe neurological, the patients with severe neurological deficits have a higher mortality. We know that we have higher mortality, about 3 times higher mortality than the general population. But you know that this is dependent on the kind of care that they get acutely, pre-hospital care and acute hospital, the hospital care that they get. And also depending on whether they're in the low middle income countries or high income countries, we know that it's actually, mortality is less in the higher income countries. Rehospitalization happens in about 30% of patients, and it's mainly due to pressure sores and urinary tract infections. So we really need to prevent patients getting pressure sores and preventing UTIs. We know that even from what we see in spinal injury, that the patients with pressure sores usually have a longer stay and poorer outcomes in terms of they usually have quite a stormy inpatient period. Then we know that 12% of clients with spinal cord injury are employed after 1 year of injury, which is quite low. And this can improve later on, but we know that generally, this is the rate of employment usually is quite low after 1 year of injury. In terms of impact of spinal cord injury, individual impact, of course, those medical and physical consequences of loss of function of the limbs and other functions such as the bowel and bladder functions. There's a loss of employment and also challenges in regard to family breakdown. Impact to the family, we know we have emotional challenges. The family is quite overwhelmed usually when one of their members has a spinal cord injury, and there's a huge financial burden, especially if the person with spinal cord injury was a breadwinner. They usually have to adapt and adjust in responsibility. roles, finances, and priorities. And there's quite a huge caregiving burden. There's a stress, there's a role strain, social isolation, and lack of community services, and even supported bereavement in the event of loss of the loved ones. And we know that it also impacts our society in terms of losing someone who was healthy, previously healthy, and contributing to the economy. And we know that there's quite a huge cost of care for spinal cord injury. The cost of care will vary according to the neurological level of injury. The higher cervical injuries will be accompanied by a higher cost of care. And some of the studies that are done in cost of care also show the location. The higher income countries are able to do more. So the costs of care are actually more because they're able to do more. And even just definition of costs, study population and time frames. And we know that a lot of those costs, especially in our setting, relate to the surgeries, trauma care, especially, for example, if a patient is in HDU and needed a ventilator, or ICU care, rehabilitation costs, long-term care, and where people are able to use more of the aids and orthotech aids, the costs are actually going to be more. So it's really influenced by the location of the care. So we know that the average expense for spinal cord injury is quite high. It goes in the range of millions of dollars, quite a lot of numbers, millions of dollars in terms of care for higher cervical injuries. And it goes even $518,000 for clients with paraplegia. And we know that the rehabilitation costs are also high. So we know that the best way to actually reduce some of these costs will be talking about prevention of complication, prevention of spinal cord injury or prevention of complication. But you know that after the first year, costs tend to go down. But you know that living costs in general are going to be high. Costs of wheelchairs, costs of aids for functional adaptation to activities of daily living are still going to be high. In terms of the challenges faced, we know that a large number of patients have unmet needs in terms of acute care, post-acute care, rehabilitation needs, and palliative care. We do not have clear statistics on Kenya and how we cater to the needs of people with spinal cord injury. So these are really big gap that we have. We also have a lot of restrictions, societal restrictions for clients living with spinal cord injury. And it's not only from the condition itself, but it's from insufficient or inadequate medical care, rehabilitation, and access to assistive technologies. And a lot of barriers, especially in the physical, social, and policy environment. We know that only 5 to 35% have wheelchair access. So thank you very much. And I think at this point, let me hand back over to Carol.
Right. Thank you so much, Dr. Agatha. That was quite a comprehensive presentation. And as you can see, spinal cord injury is a medical condition we don't talk enough about. So I hope we are taking notes so that in the Q&A section, we have questions that we can direct to Dr. So without much ado, and actually, thank you so much to the audience. We can see the love. Thank you very much. So without much ado, I will hand over to the team from KNH. So as Dr. was saying, we have the point where we diagnose our clients with traumatic spinal cord injury or non-traumatic spinal cord injury. So we are at the accident scene and we have this client taken over from the accident scene to the hospital. So the team at KNH largely works at that journey in the management of the acute and immediate post-acute phase. So Team Kenyatta, I will hand over to you. My colleague, Joseph Colley from Physio, you can take over. Thank you very much. So as we wait for Team Kenyatta and Collie to load his presentations, I saw a hand up. I hope it's not a question, or what we can do so that we can save some time. Yeah, just put in your questions in the Q&A. Oh, actually, Collie has loaded his slides, sorry. So we'll just allow Collie to continue. So welcome, Collie. Thank you. Hi, Collie. I think you're unmuted. I mean, you're muted. If you could just unmute and proceed, we're ready for you.
Okay. So this the
So as we wait for Collie, I'll probably just answer one of the questions that has been asked. For Brenda, I think the notes or the presentation will be shared on the KenH website. So I think and recorded, this session is recorded, so you can actually access those at that point. I hope that's fine. For Angathoni, who asks, how does pneumonia come about in spinal cord injury? So one of the things is that spinal cord injury is associated with a reduction in the immunity. So it means that anyone who was previously immunocompetent becomes immunosuppressed. So whatever organisms we are exposed to can easily, get us sick and go all the way from the upper respiratory tract to the lower respiratory tract. With regards to patients, as Dr. Agatha was presenting, anyone with a cervical spine injury, which affects the respiratory function, you may have secretions that the client is not able to get out, from the lower respiratory tract, and that would predispose them to infections. Then also depending on the environment, if you're in an ICU setting, for example, a client who is intubated, who is instrumented with, for example, a urethral catheter, for example, you may be at risk of getting infections. So I hope that has been answered. If you still feel there's an area we can clarify, we will have we'll have the question answered in the Q&A section. So I can see that the team from KenH is ready. So go ahead, Collie. Thank you.
Good afternoon once again. My name is Jason Collins. I have a colleague here with me. He'll introduce himself.
Good afternoon, panelists and listeners. I'm Patrick Johnson Manyara. I'm working under Joseph College.
Okay, we'll present the physiotherapy intervention on spinal cord injury patients in the acute phase. So in the acute phase, these patients usually learn directly from when they are involved in accidents, when they get the trauma, they learn into Kenyatta National Hospital trauma units, where now, depending on the level of the injury, if it's cervical injury that interferes, anything above C5 that interferes with breathing, will land these patients to ICU for mechanical ventilation. Then the other ones that respiratory stable, that do not require the mechanical ventilation, will be taken for stabilization. At the same time, the management of the affected site of the injury. So the physiotherapy part of it, when these patients learn in Kenyatta, and most of them will learn in ICU because of the respiratory is affected. So when they land into Kenyatta National, they land into ICU. In the ICU, one of the aims of the physio when you are the patients are in ICU is to emphasize on respiratory management. We manage the chest because most of these patients, when they come to ICU, they find that the chests are congested, they are not able to breathe, they are not able to clear the secretions. So they will need assistance from the physio to do that. The other thing is that we will also start preventing the indirect impairments and complications as from day one. One, through positioning. Two, through turning. You want to prevent those formation of bed sore early enough to prevent those secondary complications. And also at the same time, you want to maintain the range of motion of the joints that are not affected. Even those that are affected will also be facilitated to maintain the range of motion, because it's very important to start these things early. So the other aim is also to facilitate the active movements in the available musculature. The muscles that have not been affected should continue being exercised. So rehabilitation means you want to return this client or patient to the life as lived, the way he was living before or near to where he was living before. So in the respiratory management, assuming these patients have landed into ICU, our goals will be, one, to improve the ventilation, the air in and out, and the oxygenation of the lung. That will be one of our aims, our goals. The second one is to improve the effectiveness of the cough. Most of these patients, when they come to ICU, you find that most of them will not have that cough reflex. So you need to initiate. If it doesn't have that cough reflex, we'll do what we call chest physio and the positioning of the patient to be able to drain those secretions, to avoid those complications that will lead to what we call pneumonia. So the other thing is prevention of the chest tightness and ineffective substitute breathing patterns. Most of these patients, you'll find that the respiratory muscles and the accessory muscles of breathing will be affected. So they will have difficulty in breathing. Some of them will find themselves in what we call IPP machine, in a mechanical ventilation. They need that ventilatory support. So the next one also is you have done with the respiratory management. What is the respiratory management? You'll emphasize in what we call deep breathing exercise, lung expansion and airway clearance, and increase vital capacity. How do you do that? You do that through what we call chest physio and the maneuvers that involves clapping, shaking, vibration in aid of the airway clearance. Most of these patients find that they will not cough. You need the assistance of the physio to shake, vibrate, and use what we call the physiotherapy postural drainage position to drain the secretion. Otherwise, if you don't do that, you'll end up with what we call pneumonia, or you'll have what we call the collapsed lung, or what we call atelectasis. So the other thing is also, you'll also use what we call abdominal support or the binder to compress the abdominal content to increase the intracranial abdominal pressure, so that this patient can, the accessory muscle can assist this patient in breathing and coughing. And the other thing is you stretch and strengthen the muscles of the accessory that help in breathing, like the muscle on the neck, the muscle on the cervical. You know, they usually good in the assisting. Like now, what has been demonstrated that the manual stretching mobility and compliance of the thoracic wall can be facilitated by manual stretching chest wall muscle in the spine. So those are some of the things that you need. Now, the other thing now, when this patient comes up, now you need now to focus on other things that are more, you want to return this patient to more functional way. One, you'll do what we call the muscles that have not been affected, you'll do the exercises actively, give them resistance, because now those are the muscles that this client will need to use to be able to compensate what he's not able to achieve using the other side of the muscle. Then the active assistance. This one means that when you have what you call the paraparesis, this patient will need your assistance in doing the exercises. You'll be able to do it, but you'll need your assistance when you are doing it. And the other one is the passive exercise. Passive exercise at the same time will be able to help that patient to prevent what you call the formation of contraction and maintain that joint range of motion. And the positioning when you are doing your suction, when you're doing your turning, it's good to do that in 2 hourly so that to avoid those bone prominences that may bring what we call the bed sore, the pressure sores. And then also selective strengthening of unaffected muscles through what we call nowadays the therabands, the muscles that have been affected, use the therabands to be able to strengthen them more so that they can be able to carry out the other function of the affected muscle. Then orientation, their vertical position, because most of these patients find that they will lie down for a long time. So when you tend to change the position drastically, you'll find what we call, them having what we call, it's like the blood rushes down the lower limbs and the brains will not get sufficient blood. So they will have them, most of them are dizzy and tend to collapse. So you have to be very careful when you are rehabilitating this patient from that flat horizontal lying position to that vertical position. And also emphasize on the treatment of maximum and functional independence. You start the treatment of exercise and functional independence very early. You start sitting these patients, you start turning these patients, you start teaching them on how to turn themselves. And then now my other colleague will continue from there.
Thank you so much. I am Patrick Johnson Manyara. I will pick up from where my colleague left. Next slide. On the basic skills. My colleague also said that the orientation to the vertical position is not an event. It is transitional. You pick, this is a patient that has been lying. So you're picking the patient from the horizontal to the vertical position, but then you do it in stages. This is to ensure that you have achieved full, you regulate the body blood pressure as is required in such persons. Remember, one of the causes of these conditions also are diseases like high blood pressure. We also emphasize on the treatment for maximizing functional independences in patients. Remember that when Dr. Agada did the presentation, one of the worries was depression and mental issues. Anyone that loses functional independence is bound to go down into depression. And in such situations, as physiotherapists, you're expected to maximize on functional independence by improving the skills that are currently left. You use what the patient has or what the client has to gain what they could have done initially. If, for instance, we have a patient who has lost limb, the lower limb function, what we call the legs, you assist them on how they can be able to move from one place to another. This is where you will do the bed mobilities, the transfers, and the use of wheelchair mobilities as aids. We also educate patients on self-skin inspection to ensure that we do not have the skin breakages, as was feared initially on the complications. If you remember, the first presenter pointed out, the skin breakage forms one of the worst feared complication in a patient with spinal cord injury. On the slide figure 2022, you are able to see one of a maneuver that we use to assist patients from rolling side to side. In the event you have a very weak patient, this is the first thing that you will do to ensure that we are not getting the breakages as we are fearing. I want to go to the next slide and do a presentation on now the phase next. After we have managed to get our patient off the respiratory issues that my colleague Joseph Colley has just told you about, what next? The patient is now able to stand vertically. So where do we go? We start on what we call as mat exercises. The activities that are able to be done on a plain lying position. You see a list of activities that can be done, which include prone on elbows. Prone on elbows, why? We would want, if a patient has upper extremities, what we call the hands, as strong enough, it is always more advisable if the patient is missing the lower extremities, which are the legs, it is advisable to improve on the strength that is left up above, so that you're able to have this patient live as near normal as possible. We do functional transfers, which are transitions after we have started the rehabilitation phase. Of course, by use of wheelchair, we teach wheelchair skills. On patients that are strong enough to bear walking around, which is ambulation, we shall be able to ambulate patients either on wheelchairs or out of wheelchairs. On wheelchairs, we use the upper part of the body, while seated, of course, and on patients that are able to manage without the necessary use of wheelchairs, we teach them crutch walking using crutches, among other aids, which include walking frames. We also educate on prevention, health promotion, and fitness and wellness. Why this? At this stage, we've talked of this stage as the post-acute stage. If you remember the acute stage where my colleague talked about a lot of concern on the respiratory issue. Now, what is called the subacute or post-acute is a phase where you're deeply concerned about what that particular person, patient or client is thinking. What next for me? This is someone, let me give an example of a mama mboga, and suddenly, after being involved in a traffic accident or a fall, sustained a spinal cord injury, what next? That is where now you look at the goals of that patient and hit the road on active rehabilitation aimed at, one, having the patient as independent as possible, achieving functional mobility so that they are able to live day by day. And we want this as independent as possible. We have movement strategies that are tailor-made to particular patients, each as per assessments, bearing in mind the impairments that the patient has had, and also working in hand with a multidisciplinary team that is comprised of all the medical teams as known. I would want of importance, I would want us to note the strengthening, the what we bear on spinal cord injuries on patients who mostly have had spinal cord injuries but are left with strengths that they are able to use their upper extremities, which are the hands. It is very important to try and strengthen the muscles as highlighted. Why? Those are some of the muscles of mobility that now take over to use the hands as the legs now. The patient has to transfer themselves. They have to swing, for instance, if they will use the push apparatus, which are the walking frames. The strengthening exercises should be performed not less than 2 times a week, going to a maximum of 4. That is with supervision, of course, and in the absence of supervision, patients will get programs that they do time and again. Of great importance is the posture of that patient. If we remember from the first presentation, Daktari talked about autonomic dysreflexia. If your patient has a poor posture, that is automatically a candidate for dysreflexia. You may not want to go there. Locomotor training, which is the movement, it is more or less what I explained earlier on. I will skip that bit, and we have some pictures or an image in figures of what we are able to do and assist in doing. This is a take-home message that is specifically from my colleague, Collie. Collie always tells me that there is no specific recipe for treatment for spinal cord injuries. All interventions planned comes with appropriate reasoning, justification based on your assessment and examination. And Collie also continues to add every day that it is also from a patient to a patient, bearing in mind patient own preference. The duration of care is as labeled. Thank you so much. I will hand over to the occupational therapy team.
Greetings. Thank you very much, colleagues from the physiotherapy department. My name is Mickey Baron. I have a team here who will be joining me. I have 2 of my colleagues. They'll introduce themselves as we continue with the presentation. No? So my main aim is to try and bring out occupational therapy management of spinal cord injuries, and how do we work with our patients to promote functional independency. I know a lot of people might be asking themselves what occupational therapy is. Occupational therapy is an aligned health care profession. As I wait to share my screen, is an aligned health care profession that involves the therapeutic use of everyday activities or occupations to treat the physical, mental, developmental, and emotional alignment that impacts a patient's ability to perform.
Apologies for that technical hitch. We're working on it. We'll be resuming in a bit.
Okay, as you're working on that, I see there's a question here where someone asked what SCI stands for. SCI stands for spinal cord injury. When we use the letter T before the SCI, we are referring to traumatic spinal cord injury. When we use NT before SCI, we're referring to non-traumatic spinal cord injury. So I hope from Dr. Agatha's example and also from the physiotherapy team, you're able to understand what is attributed to trauma causing spinal cord injury and which is non-traumatic. For Asia, that was the tool that we used to assess a person who has sustained a spinal cord injury. That refers to the American Spinal Injury Association. So that is the tool we use to assess and define the motor deficits and the sensory deficits. I hope that is fine. So we'll continue back to the occupational therapy team. Thank you.
Thank you very much, Daktari. As earlier on, I was trying to introduce what occupational therapy is and our role in spinal cord injury management. And I talked about what occupational therapy is. Occupational therapists are practitioners who use therapeutic techniques to improve, rehabilitate, or maintain a patient's motor skills and overall abilities to perform everyday activities. Occupations refer to everyday activities that people do as individuals, in families, or with communities to bring meaning and purpose. Occupations are basically everything you do. When you wake up in the morning, you shower, you do your self-care, and then you go to your work. We look at your productivity, and then we look at your leisure, how are you spending your leisure. So if you've suffered any injury, like the spinal cord injury, these three domains are affected. So that's where now it is we come in. Occupations includes things people do, need to do, want to do, and are expected to do. So what sets occupational therapists apart is our focus on occupations as the tool we use to restore, we use it to rebuild and enhance our clients' lives. So when we say occupations, we mean everyday activities that we do, and using these activities as therapeutic tools to help us build better lives for our patients. Among the occupations people participate include, we have activities of daily living. My colleague is going to expand more on it. Work, leisure, play, education, and social participation. Therefore, adapting the activity to or modifying the environment support clients' occupational engagements. I want to take you through what the occupational therapy process is. When you refer a patient to us, when we are on the acute phase of managing the spinal cord injury, what are these occupational therapy processes that are involved? When we're talking about an occupational therapy process, is a client-centered approach focused on engagement in occupations. We use occupations to rehabilitate or to use it as an intervention to provide services to persons, groups, and a population. So the occupational therapy process, we have the various parts. We have the evaluation and assessment phase. This is the occupational therapy process. The evaluation process is focused on finding out what the client wants and needs to do, determining what the client can do and has done, and identifying support and barriers of health, well-being, and participation. So when we are doing assessments, we use our standardized assessment tools. We also use the standardized assessment tools. The types of standardized assessment tools we use the Canadian occupational performance measures to be able to know the performance level of our patients with spinal cord injuries. And then we go to the intervention phase. The intervention process is designed to facilitate clients' engagement in occupations and to improve health and well-being. The intervention process includes, we have the intervention planning. This is where now the therapist, together with the client, remember using a client-centered approach, we sit down to set up SMART objectives or set up a treatment plan. And then now we do an implementation, and then we do reviewing of our interventions. After that, now we look at now our outcome measures. After you've come to the after an occupational therapist has seen you, what are the outcome measures? The outcomes are the results of that a client achieves through occupational therapy interventions. Outcomes are established using assessment tools and outcome performance measures. The success and effectiveness of occupational therapy services in improving clients' occupational performance and participations are demonstrated through the outcomes. We can have a patient-reported outcome. This is where now the patient, tells us he's satisfied with our services, he's confident with our services, and also here the outcome phase, we looking at the discharge planning. This is where now we do discharge and we refer accordingly to the various cadres that are available. So basically that is the occupational therapy process. Now we want to go into depth the management of spinal cord injury by occupational therapists.
Thank you very much, Mike. Hello everyone, my name is Paul Elijah. I'm an occupational therapist, Kenyatta National Hospital, and I will be taking you through the role of occupational therapy in the management of spinal cord injury in the acute phase. As an OT, in the multidisciplinary approach, OTs play a very important role for patients at the acute stage, whereby you realize most of these people who have suffered the spinal cord injuries are taken to the hospitals, and at the time they have been taken to the hospitals, you realize most of them, they are not able to perform most of the activities of daily living, owing to the problems or the weaknesses emanating or resulting from the injury to the spinal cord. As OTs, we come in and do an evaluation to ascertain the areas of weaknesses and some of the areas, some of the activities which these clients or patients are not able to perform. And you realize most of these people, due to traumatic psychological trauma which they go through after the spinal cord injury, you realize you have been walking, all of a sudden you are not able to walk. You have been doing everything for yourself, all of a sudden you are not able to perform anything on your own. So as occupational therapy, we come in and address all those issues, starting from the activities of daily living. And activities of daily living starts from the self-care issues, bathing, toileting, being able to do grooming. You realize all those areas as a result of spinal cord injury, these patients tend to suffer serious problems in performing all those basic activities of daily living. So as OTs, we come in at the acute stage and train these patients how they can be independent and perform optimally, even with the challenges of the spinal cord injury. And how do we achieve this? We achieve this by training them on how they can use the literal abilities they have. For instance, if this is a patient who might have suffered a spinal cord injury and maybe they are paraplegic, you realize even if these patients are paraplegics, due to psychological trauma emanating from the spinal cord injury, these patients will be so much traumatized to an extent that even they don't realize that they can be able to use their upper limbs. So as OTs, we come in and train them on how they can use the abilities they have to perform the activities of daily living. They can do their self-care issues. They can bathe. They can be able to clean themselves. They can be able to perform toileting even without much of the help from the healthcare team. And again, still these patients at the acute stage, due to the long stay in the hospital or being in one position for long, you realize they tend to develop, as my colleagues have alluded to, they develop what we call pressure sores. So as OTs, we come in and make sure that we improve their quality of life by making sure that they don't develop pressure sores by providing them with what we call a lamp stool. Lamp is a specific material which helps them to cushion them to enable to ensure that they don't develop pressure sores due to long stay in the hospitals. Again, still on prevention of the pressure sores, we also provide them with what we call air rings. Air rings are especially designed tools to enable these patients cushion the pressure areas. For instance, the occiput, the calcaneus, the gluteal area around the sacrum, and around the greater trochanter, to ensure that they don't develop pressure sores, because if they happen to get some of these secondary complications secondary to spinal cord injuries, this one completely weighs them down psychologically, and it really traumatizes them when they are in their acute stage and they are admitted. So basically, what I'm trying to explain is that as OTs, we come in to just ensure that we improve the quality of life for these patients who have been who have suffered spinal cord injury, and ensure that their quality of life is improved. Still, we do a follow-up on a post-acute stage, whereby these patients now they are not admitted. They have been discharged through the rehabilitation team. So as OTs, we come in and assess these patients. What are they able to perform? What are they able to do? Assuming, for instance, someone has been discharged from the ward and they have been told to go home. As OTs, we come in and do an evaluation, even at the home environment, to ensure that these patients, even with the limited capacity, they are able to perform everything. They are integrated into the society, and they are able to live independently without depending on much on other people. So how do we achieve this? We do what we call training and home modifications. So if they have been discharged from the hospital and they have been told to follow up a rehabilitation schedule, so we do assessment, try to come up with their challenges they are facing, probably at the home environment, work environment, and even if it's as a school environment. We do an assessment and ascertain all the areas whereby they might need help. For instance, assuming this is a woman who has suffered a traumatic spinal cord injury, and she has been discharged from the hospital, she has a lot to perform at the home environment. So we do an assessment of the environment where they live, and do critical modifications so that we ensure that they are able to perform the activities of daily living. They are able to cook, they are able to wash, they are able to participate in societal duties, and ensure that they live as comfortable as they were living before. Although, owing to the spinal cord injury issues, some of these people, you realize that they might not be able to return back to their usual occupations. So we can also advise them to see how they can adjust, or they can even change their profession, so that they can be able to live independently, not necessarily looking at the issue of the disability they have suffered. So I've talked about the home and work assessment. So these modifications, they enable these people to be able to perform and act and participate in activities of daily living or perform their daily routines optimally without necessarily having to be weighed down by the levels of the injury. School and because now you see the spinal cord issues don't choose which gender or age or whatever. So a school-going child might suffer spinal cord injury, and this child has to continue with education. So what do we do after they have gone through the acute stage? We'll follow them up in their post-acute stage and ensure that these children are able to go back to school, look at the school environment, look at where they sit, look at how they perform the activities of daily living, ensure that they are able to participate in play. Yeah, ensure probably if they are using a wheelchair, how safe is this wheelchair they are using? We ensure that we assess the environment, we assess even the assistive device they are using. Probably if they are using the wheelchairs, we ensure that they are able to access the classroom using the wheelchair. We ensure that they are able to sit properly, assuming the proper postures in order for them to be able to perform the school duties. Still on issues to do with the functionality, we also encourage these people and even talk to the family members, because you see, when sometimes you suffer a spinal cord injury, sometimes the society might view you as a burden. So we try to talk to the family members and ensure that they understand that this is not a burden to them, and ensure that this person is functional and together with the levels of injury this person might have suffered. To aid that, we use what we call assistive technology, which I would like to invite my colleague to take you through the aspect of assistive technology and how it comes in to aid these people perform their activities of daily living or live independently as much as they can without too much help from the other peoples of other members of the society. So thank you very much. I hand over to my colleague to take you through the assistive technology in OT. Thank you.
Okay, thank you very much, Paul. My name's Ivan Sokongo, an occupational therapist. I'll be taking you through the assistive technology. First of all, individuals with a spinal cord injury, just like patients with any other conditions, have a right to lead good quality life and independent lives. However, due to the limitations presented by this condition, it is also impossible to live a good life without some assistive devices. Some of what I understand is every spinal cord injury is different. So some of the adaptive tools may benefit some more than others. You may wonder what is an assistive device. It is any equipment, product, software program that is used to maintain or improve the function capacity of a person with disabilities. And as you can see from your screen, there are some limited, no, there are many, but picked some of them which you can use them as a form of examples. As the first one, you can see it's a universal cuff, the ones you're seeing with a pen, a brush, a knife, spoon. Universal cups are one of the most useful tools for people who have limited controls of their hands. First, you slip item like a utensil, pen, toothbrush into the slit. Then you place your hand between the item and cuff. The items remain secure so that even if you can't grip objects with your finger, you can still eat a meal, draw, or groom yourself. The second one you're seeing is it is a transfer bench. A transfer bench can help individuals with quadriplegic safely get out of their wheelchair and into the bathtub. Learning how to maneuver yourself in and out of the transfer bench can be complicated and requires quite a bit of arm work.
So we recommend that only those with minimal upper minimal weaknesses attempt to use on their own. Transfer benches allow you to remain seated and wash up without worrying about slipping or falling over. There are also grab bars on the side that can help stabilize you. The other equipment is the shower. That's the shower hose. Another assistive tool that can make bathing easier is shower hose with a handle shower head or head holder. It allows you to bathe with minimal movements of the body. Instead of turning around and risk slipping, individuals can move the shower head. The other one is also, the other one you can see is the image above is the holder that you can slip up and down the bar for extra convenience. The other one you're seeing is adaptive utensils. Adaptive utensils. Adaptive utensils are designed to help those with weak hand and wrist control. The photo you're seeing shows a fork with a long bendable form handle that can be molded around your arm so that you don't need a strong grip to pick up for food. Those are the two, and the other one is the last one is a leg lifter. A leg lifter can be very extremely helpful for patients with limited strength to lift their legs. Once your foot is inside the loop, you can use your arms to maneuver your leg into or out of the wheelchair, bed, and chairs. The other it is not captured in the slides. We have assistive technology. This one basically is for quadriplegic. This is an area which I think like as occupational therapists, we need to think through in terms of technology, because you are heading to the technological era. Due to this technology, the way it's upcoming, I thought of quadriplegic patients, what they are missing out so much in terms of technology. You see now these people are on WhatsApp, TikTok, doing all this technology which can offer. And some of the patients, like the quadriplegic patients, cannot enjoy or do these things on their own. This gave me an interest to come up with a software program for them to be able to operate devices without touching. This one, they can be able to do mobile transfer. They can enjoy YouTube, attend meetings the way you're attending, chat on WhatsApp, so do all the TikTok the way people nowadays are even earning money through TikTok. That can be also a source of employment for them, as much as they are not able to physically able to do anything, but they can use that program to help them to do, like, especially like my colleague said, we find school-going children accidentally develop a spinal cord injury. Does this mean this child stops learning? No. Through this program, which I formulated, it can help them in terms of their learning. It is through a few installation and settings of a device that I can be able to use this device in terms of even learning and be able to type with it. But remember, they are not touching. Those are the kind of the area of interest I think now we should go in terms of technology, so that we can help our patients with spinal cord injury. Because of time, that one could be a good demonstration for you, but because of time, I think maybe that one could be another session for another day. Thank you very much.
Thank you very much, our able audience. We basically borrowed most of our literature from the American Occupational Therapy Association, also from the World Federation of Occupational Therapists, that's the WOFOT. Also, we borrowed a lot from the Kenyatta National Hospital Occupational Therapy Work Instruction Manual. And also, of course, I just wanted to echo out, occupational therapists are licensed and registered by the Occupational Therapy Council of Kenya to practice. Yes, and just a takeaway home, everyone has activities that define who they are, whether it is work, tasks, artistic expression, leisure pursuits, school responsibilities, or play activities. So occupational therapists, we use occupations to rehabilitate you. It means you are having fun while being rehabilitated. We are doing more practical things. If you had lost your function, we do it more practically for you to be able to perform a certain occupation. Yes, thank you very much. And I think I'll hand over to the other team. Yes, Dr. Carol, please. Thank you.
All right, thank you so much, Team Kenyatta. That was such a brilliant presentation. We can see the audience is really, really appreciating and acknowledging you. Thank you for staying on with us. So we have the final stage of the presentation where now KNH team has appropriately managed and has now handed the patient to us at the National Spinal Injury Referral Hospital for us to manage. So we will be taking over, and I will just start with the introduction. And I will have my team, my colleagues. We have Miriam Wathe, who's an occupational therapist, Wale Simburu, and Mr. Masinde, who's our physiotherapist. So I'll just start off the presentation, and then they will join me somewhere in the course of the presentation, but you'll just allow me to give you just a brief history because I know a lot of us don't know the National Spinal Injury Referral Hospital. And yeah, we'll just introduce the hospital briefly so that you know who we are. Yeah, so that we can, just talk a bit more about the post-acute phase. So you'll just allow me to share my screen. I'll just go off briefly. I'll just share my screen so that you can see my presentation. And then look. So just I'll go through the journey of the patient, the spinal cord injury patient in Kenya, a brief about the hospital, then at the post-acute care and the rehabilitation services we offer, and then look at the opportunities for collaboration and the days I've just spoken briefly about. So as we look at the journey, we mentioned that there's a point where we will diagnose the spinal cord injury. As we look at the traumatic spinal cord injury, this is usually the accident scene. We've gone to Kenyatta, we've seen what care is being given. Our team there has ably managed this patient and referred them. So what you see is we are actually at very high level in the hospital, in the healthcare system, level 5, level 6, which we are also at the NSIRH. So the end you can see is we're taking our client back to the community. And I really loved what the occupational therapy team discussed. How do we actually allow this client who's gone through such a devastating injury, manage them physically, mentally, rehab them to the point where we actually allow them to go back into the community. So these are just some pictures I picked from the internet, so disclaimer. In terms of who the spinal cord injury patient is, it's a farmer, it's a child who was swimming, it's a father, it's a baby who fell accidentally, a student who was climbing an avocado tree. For some reason, we have quite a number of falls from avocado trees. We have a mom. We have a child who was running and was attacked by a wild animal. So quite a diverse population. And these are people who are more or less, they were well. They were like me and you walking and then got very traumatic injury. And then they find themselves in this position where they have to go through ICU, through the hands of a lot of healthcare workers. And their journey is not ending. They are going into another facility. So this is where we come on board as a National Spinal Injury Referral Hospital, which I'll abbreviate as NSIRH, which is our level 6 hospital. We basically just specialize in matters spine and spinal cord injury. A lot of you know us on the rehab space because that's the work we've been doing. So the hospital is the only public hospital in this region in Kenya and Central Africa offering these kind of services. Our history, briefly, it was started off in 1944 by a British citizen, Amani Cheshire, who wanted to have the soldiers who were injured in the World War II have a place where they could be taken care of. In 1963, look, we actually part of Kenyatta. We were annexed from Kenyatta, and in the year 2000, we were declared a National Referral Hospital. Our current bed capacity is about 31. If we expand a bit, we're around 33. I saw someone ask a question about how do we increase how do we allow people to actually get access to the hospital? So you can see who we are, but we do have a big outpatient service provider. an outpatient service. So our core mandate is actually to provide acute medical intervention, rehab services, reintegration and follow-up of persons with spinal cord injury, and promotive and preventive health services. Because of the nature of the hospital, as we are growing, we don't give much in terms of acute, and that's why we rely on our partners, including Kenyatta, the county referral hospitals, the private hospitals, to give the specialized care. So our vision is to be a center of excellence. As someone asked, we are looking at that. And the hospital is actually in transition, probably into a semi-autonomous government agency in the near future. So look out in that space. And we want to be a center of excellence in care, teaching and research in spinal health and trauma in Africa, with our mission of providing comprehensive specialized spinal health services with excellence, using innovation, cutting edge, and technology. And I like what was my colleagues from the occupational therapy said. This is the modern world. What is it that we can do for our clients to be more with it and to understand what is happening and how to adapt to the world? So as we look at the pathway of the acute patient, this has already been spoken of, and this is what we were thinking of. And as we grow as a spinal injury, so we do manage patients with non-traumatic spinal cord injury, which we said was NTSI, as opposed to the traumatic, which is TSI. For the unstable, we largely don't manage that population because we don't have an accident and emergency. The hospital at the moment is not that big, but the plans are underway to expand it. For the stable ones, for those, for example, with the degenerative changes, those who strain their backs, maybe lifting heavy things, we do see them in the outpatient department, where we have specialized clinics with those specialists. And we also do have our colleagues in the physiotherapy. We have our colleagues in the orthotrauma, occupational therapy, orthopedic tech, who will manage them. In the post-acute phase, where we've said the client is now stable and able to sustain a rehabilitation program, we have our patients coming in from two pathways. So internally, our clients who've had surgery or been referred from our outpatient department, and where you come in as our partners, Kenyatta, the county referrals, the private hospitals, and even from our clients who are outside Kenya, we do have that pathway for external referrals. So the question is, and I'm sure you're asking, how do you get into spinal injury? So we're actually working very hard on those mechanisms. At the moment, we do have an admissions desk where you can make an inquiry. And because of the limited bed space, and our patients actually stay with us for quite a long time, as you can see, because we are doing a lot of reteaching. People who could walk and now have to move around using wheelchairs, who have to dress using assistive devices, who have to figure out how to use ramps. So we actually stay with our patients on average from 1 month to 12 weeks, which is about 3 months. So once you come to our admissions desk, our team, the admissions team, will be able to guide you. So one of the things that is important, and I really like that the KNH team highlighted, is the profile on the patient. What happened? What is the score? Are they quadriplegic? Do they have quadriparesis? Are they paraplegic, paraparetic? What is their mental state? What is their needs in terms of assistive devices? Who are they? Is it a teacher who we want to go back to teaching? Is it a student? Is it a child who we have to look at long-term pathways? Is it a mom who has a desire to have children? So there's quite a lot we need to put into context so that we now sit as a team, devise a rehabilitation plan that is appropriate. I know I've put a very interesting term that many people are not familiar with, a physiatrist. So that is actually a subspecialization in medicine for those who've studied, MBC, HB, who go back to school to learn on, physical medicine and rehabilitation. So they actually direct the rehabilitation program as doctors. But we also, we don't have that currently in the country, but we have our colleagues, the physiotherapists, occupational therapists, orthotech, mental health. So the whole team that is available. It's just that in the country, we don't have physiatrists. So this team is able to sit, assess, and then devise a rehabilitation plan. So at the center, and we really do want to be patient-centered, as I've mentioned. Where is this patient going? Who are they? It's a person. It's not just an item. It's not a textbook. This is a person whose needs we really have to address. So for those who are unstable, we will refer them to the specialist services. So depending on what do you have, DVT, which we need to manage, is it a UTI, is it sepsis, pressure ulcer? And as you can see, that is really important to give the information because the care is based on that. For those who are stable, who don't have, extra attention or extra needs, we send them straight to the rehabilitation program. So one of the things that is exciting for us, and for those who know my other working area is sports. So one of the areas we're looking at for rehab is actually also sports. So not just rehab in the space of for people with disabilities, but remember, people with disabilities make excellent athletes. So that is a plan we have at the hospital. Watch out for that space as well. So now for the reintegration services, what we say is we want to bring in our clients. We want to help them to, go back to who they were. So we do have that rehabilitation program. Sorry, I think the slides have just interchanged briefly. But then remember, reintegration is a process. It's not, we don't do it once. So this is something we really need to think of and really need to, train the client. If it's someone who maybe wants to learn new skills, for example, tailoring, who wants to paint, who wants to become an influencer on TikTok, who wants to go to school, we really have to think through as a team and how we are going to, put this reintegration as part of their package. And you saw the physiotherapy and the occupational therapy really talked a lot about, preparing this client to go back to the community. I did not mention the team because, as I mentioned, it's a really big topic, but the mental health, it's really very traumatic for someone to suddenly lose the ability to walk. For those who have quad states, they're not able to use their hands. Imagine, you cannot comb your hair, you can't dress. So it's a very traumatic episode. Not adding, imagine even thinking about the accident, for example, someone fell from a height who went diving. So there's quite a lot that we do in the physical space in rehab and also mental space. There's the nutrition team that comes on board that also now sort of, just sits and looks at the client, because we then have the risk of undernutrition and overnutrition. Undernutrition, you've gone through so much, the client has gone through so much trauma, they're not able to eat. So they will lose weight. But then the challenge is when they start eating and we make plans for them to feed, are we at risk of them gaining weight, at risk for cardiometabolic diseases, because they're not physically active, So the risk is you just keep eating, but you're not active. So there's a very big team that comes in, the assistive devices that they need, the crutches, the wheelchairs, the feeding devices, the reachers. So I'll just take you through some pictures. So my colleagues, occupational therapist, physiotherapist, and the orthopedic technologists, I'll just give them a few minutes, but I'll just take you through some slides so that we can see the reality of who this patient is and what we're preparing them for. So as we can see some scenes, these clients are going back to these homes, the arid area. I think this was Muranga, where it's very hilly, and Kericho. Kericho is also cold. We know Aberdares is cold. We look at, the western part of the country. There are some who may be living on Rusinga Island. There are those who come from Budalangi, it's flooded. There are those who come from the Rift Valley. There are those who come from the coast. So it's very diverse. We have clients who need to go to very different places. They're used to very different things. So we prepare them for that. We don't want them in the hospital for too long. The next picture just shows in terms of the different settings. That's an urban setting. I think this is Pipeline. We have Madari, we have the high rise, with those who comes from the suburban areas. Just think through it, not now, but how do we handle this patient and take them back to that environment? The next one just looks at some of the rural settings, where we have those who come from well-organized, fairly organized rural settings, and those who come from the Manyatas, they come from the semi-arid area. How do we, contextualize all this? And even when it comes to the referral facilities, because you want them in the community, should they have a need? Do they have to travel all the way to Nairobi? Or can we actually meet them where they are? Which connections do we need? I know someone talked about policy. Where is the national policy so that the person in the county, in the dispensary, is comfortable managing this client? And you never know. It could be a family member. It could be you. It could be me. So we need to just really think through and see how to put this picture together. The next one just looks at how we want to, we say our clients need to be independent. Just look at that picture and think about where we are in Kenya. Once we've trained our clients to use wheelchairs, where will they use them? The next picture, this just shows a transport system. Of course, you can see this is not Kenya, but I think we really need to think about our transport system. People need to go to school after their, their rehab programs. They need to go to work. They want to go and watch a concert. They want to go to Uhuru Park, the new refurbished one. How do they get there? Next picture. This one just shows even just accessing buildings. What do our buildings look like? Do we tell people where they can actually, access through? Look at the guy, our client there at the bottom of the stairs, just thinking, and this society is not inclusive. My colleague just spoke about apps. Look at the door in this, the last picture, where we can actually have smart doors. The moment you're there, you don't need to use your hands. So yeah, we really need to be more inclusive. And the last one, we'll just look at some of the assistive devices, which my colleague has mentioned. And the very last one, look at our people. They're in school, they're in their homes. Look at the adjusted home, as the colleagues in occupational therapy spoke about. Look at the heart, look at the Manyata, look at the housing pipeline, look at the house in Madari. What much do we really need to do? So I'll just hand over to Mr. Masinde, Wallace, and Miriam. You can just talk briefly and just let, give our experiences on how we manage our clients in this phase. So Karibu, Masinde, Wallace, and Miriam.
Thank you very much. I hope I'm clear and loud.
Yes, Mr. Masinde, we can hear you.
Yeah, this is John Duchwala Masinde. I'm a physiotherapist at National Spinal Injury and Referral Hospital. And just like Doc has mentioned, our colleagues in Kenyatta have really put a lot in giving some information that we need to understand. And at the moment, at National Spinal Injury Hospital, we receive patients from various institutions, and they come already with complications. And now this one's maybe is a call to all my colleagues across the country and everywhere, that when a patient has spinal cord injury, let's start rehabilitation a bit early enough so that we don't have to come to manage the complication at the National Center. Now, what are the main specific goals for this, our physiotherapy objectives? Now, this mostly we consider at, we want to restore mobility of the patient, we want to strengthen the patient, and we want also to ensure there is function for the patient. And most of the, just like my colleague alluded, that each patient goals are individualized. So basing on the level of the injury and severity, and then also on the personal circumstances. And now most of the goals that we want to achieve, one is maybe gaining mobility, as I mentioned. Then there is enhancing range of motion. So enhancing range of motion, this one will prevent the musculoskeletal complications. We have the contractures and perhaps heterotrophic ossification and other related cases. We also have, we do promoting independence in ADLs, so that once the patient is strong enough, he can be able to actively be able to be independent in doing the ADLs. Yeah, at the same time also we manage the spasticity and muscle tone. The muscle tone and spasticity can be managed also as we continue what we do in our programs to ensure that we're trying to prevent all those spasticity to our patients and increase the muscle tone or improve the muscle tone. Then addressing the needs for respiratory function. Remember, our colleagues mentioned that above C5, the high risk of one getting a respiratory distress or maybe having respiratory issues. And now we come in to continue addressing the needs for respiratory function by doing our chest physiotherapy, as my colleague mentioned. But now this is not in acute. This mostly we do in post-acute stage. Then we also do the prevention of secondary complications. The secondary complication, which we mentioned also through the doctor's presentation, might include in our case pressure sores, and then also pneumonia. Now, those are the secondary complications. We also do management of pain. Pain management, we do it either by usage of moist therapy or even manipulations, and then also some TENS or transcutaneous electrical nerve stimulation. Yes, it does a good job, especially in managing patients for pain management. Now, physiotherapy also will come in handy in giving psychological support for our patient, because we We join our counseling groups to ensure that we counseling our patient, we giving them the coping strategies on how they can be able to cope in this life. Mostly because we're also focusing on maximizing the quality of life of this patient. So at the same time, also we're looking at the cardiovascular fitness of the patient. Remember, this patient is not active. Someone who was very active, so stands at high risk of getting DVT or maybe cardiopulmonary cardiovascular complications. Now we come in to ensure that there is fitness in the cardiovascular system. Then we also promote neuroplasticity by doing task specific, especially in training, constraint induced movements. Then also we do functional electrical stimulation for our patients. Then we also come in with our colleagues in occupational therapy and orthopedic technology in promoting or training by usage of assistive technology training. Now this one's mentioned already, the likes of wheelchairs, the walkers, adaptive equipments, and many others. We also participate in community reintegration to ensure that we are able to understand where is this patient going and how are we going to navigate in all those areas to help our patient be able to understand the society. And at the moment also we are working on a program whereby we can be able to be helping our patients to be able to integrate in the community. Because most of the time after we integrate our patients in the community, most of them, perhaps they may not be able to be accepted in the society. And that's a gap that we need to come in and strengthen it on how we're going to ensure that these patients are accepted the way they are in the society. Because having an injury doesn't limit one from being a person of that society, doesn't limit one from being a mother, a father, or even a brother. And that's a person who needs attention. And then at the same time, also look at, we also train on fall prevention, especially when we come in with exercises, like we're doing the balance training, gait training, and environmental modification. What Dr. has just mentioned, we also train our patients on doing those modifications in their environment. At the same time, this patient, we also do education and self-management. Why do management and education? It's because this patient, we need to understand the situation. We need to understand what kind of injury. Is it a complete injury? Is it an incomplete injury? To which level? Because once we understand all that and train our patients, then eventually they'll be able to accept the situation and they'll be able to cope up with the environment. Then also do the monitoring and progress. And we can also eventually do the adjusting of our treatment. How do we go on by monitoring the progress? Now we see what the patient has achieved. We'll be able to increase or maybe to modify or adjust the treatment because the patient is continuing is continuing well. Then we also look at family and caregivers. We train those people, the families and caregivers, such that when they come in, we need to allow them to, the patient, we look at the patient holistically, not only as an individual, but also because what we understand is that when if one person is affecting the society in a family, then eventually the whole society is affected. So we train our patients, their caregivers, and their family members on how to be able to support these patients. Then we also look at the social support. How do we come in? So at the moment, we're also doing the facilitation or connection with such patients to their peer groups because we have been having these patients all through. So we identify the areas where these patients coming from. Then we can be able to map and also connect them to other patients who've been there. And the reason for connecting them with other patients is that to enable them to understand that they are not alone. There are others also who went through the same situation and they are coping, so that they can also continue coping at the same time. We also look at promoting independence and self-efficacy. Now, all that we do it by encouraging the autonomy, so that the patient can continue to be independent as much as possible. So those are the issues that we handle in physiotherapy. And how do we do it? Now, after the acute stage, we have some things that we do. Strengthening the upper limbs is very vital, as my colleagues mentioned. They will also have a tilt table in a tilt bed in our facility. We use, especially when we're managing the pressure issues. And then we also have the standing table. We train them, especially the paraplegic, on how to be able to put weights on the lower limbs. We also have the parallel bars. We use them to train, especially for early mobility. So the early mobility, either by using assistive devices, technology like CAFOS and EFOS from our colleagues in orthopedic technology. Then at the same time, also we train them on how to use a wheelchair. Now, all those issues, we do them to ensure that the patient remains independent as much as possible. And that's the autonomy. Thank you very much. I hand over to my colleague, Miriam Mwathe, our occupational therapist. Thank you.
Greetings, everyone. Can you hear me?
Yes.
Yes, go ahead. Go ahead. Hi, Nelson.
We can hear you, Miriam.
Hi, Miriam. Can you hear us? We can hear you.
Can you hear me?
Yes, maybe you can just speak in 2 minutes, just briefly. I'm sorry, I think we are just excited about speaking. So maybe just 2 minutes to just highlight the occupational therapy in this post-acute phase, and then Mr. Mburu, just another 2 minutes so that we can conclude the session.
Okay.
Thank you.
So thank you. A lot has been said by my colleagues, and I think I'll just capture a few areas as part of the rehab team that have not been captured. And in occupational therapy, we do disability assessments, which is very key for our patients. And we are also involved in sexuality post-spinal cord injury. We understand that these people had roles as fathers, mothers, and others are also interested in starting families. So we do a lot of sexuality post-spinal cord injury. There's also a bowel and bladder program that we take through our patients so that they are able to be weaned off diapers and catheters. We also do a lot of splinting for the upper extremity, especially for the patients who have a higher up injury, the quadriplegics and those with quadriparesis. And we also do functional assessments to enable these patients go back to work, school, and join the community. The other area maybe I would like to talk about is we do a lot of psychoeducation so that we can empower our patients, and this plays a vital role in reintegrating them back to the community. So I think I'll highlight on those few. And also another important aspect is the skin inspection to prevent the pressure sores. And I will now hand it over to my colleague, Wallace.
Thank you very much, Miriam. But Miriam, we will give you a whole day in September. Miriam is a brilliant occupational therapist, very, very, very well. I mean, a lot of wealth of knowledge, and we owe you a day, Miriam. Thank you, Wallace.
Thank you
please.
so much.
Thank you, Miriam. Wallace, please.
Yeah, good afternoon.
Afternoon.
Yeah, my name is Wallace Bro. I'm an orthopedic technologist at the National Spinal Injury Hospital. And I can give a highlight of what orthopedic technology or orthopedic technology role in spinal injury patient management. And basically, orthopedic technology are the people who provide the assistive devices or orthotics, talk of assistive devices that help restore the function or improve function. Upon sustaining a spinal injury, the patient loses function. They lose strength of some of the parts of the body. Talk of the limbs, be it lower limbs, they are not able to stand. And talk of the neck, at times they are not able to hold your head upright. And we are the people who prescribe these orthotic devices. Talk of those who need cervical collar. We have different types of orthotic devices that assist these patients. Some we have cervical collar for those who have injured at the cervical region. We also have thoracolumbar corsets, those who have injury at the thoracic region. And we also have lower rib orthotic devices. We talk of ankle foot orthosis, that is for the lower ribs. We also have knee ankle foot orthosis. These assist patients to stand, having lost power to the lower ribs. They are not able to stand, and they need these assistive devices which assist them to stand. We also have H CAFO. This includes the hip. Basically, these assistive devices are categorized according to the region or the area that they intend to assist. And we have cervical region, just like the body is arranged, cervical region, thoracic region, sacral region. We have cervical collar, we have thoracic, thoracolumbar corsets. We also have radial orthotics. We talk of knee ankle foot orthosis, AFOS. We also talk of HCAFO. They help in ambulation. Another thing that these assistive devices help, they help in posture, be it when sitting, they give the correct posture. Think of a patient who has scoliosis following spinal injury. They are not able to sit upright. There's a compression of the internal body organs. Think about the lungs. One is unable to breathe. Think about the digestive system. And once one gets the thoracolumbar corset, it helps to one to sit upright, and one is able to breathe, and even is able to digest. Other ways that these assistive devices help with the following spinal injury, one may be limited, or one may be confined to the bed. This will affect circulation. But if one gets these assistive devices, they are able to stand. Then it helps even improve circulation, even blood circulation, and even as they get ambulated. These assistive devices also in ambulation, having it in mind that having sustained a spinal injury, these people are not able to stand, they are not able to walk. But once they get these assistive devices, then they help them. Once they get this, others they're able to help them to ambulate, and they work in addition with the physiotherapist, among other healthcare workers who assist in ambulation. We also think about things like walking frames for workers. Having a sustained spinal injury, one is not able to, one doesn't have balance. But once they get these workers, then they're able to give them balance. We can also talk about crutches, which also assist them, depending on how the type of injury that one has. Crutches help them. We can also talk about wheelchairs. There are different types of wheelchairs which these people can use, which can help to move them from one place to another, and they can help them even carry out the activities, and even move, and even able to become independent even as they use these devices. Yeah, basically that is what I would highlight. I had more, but having been limited by time, those are the highlights that I could give for the time given. Thank you.
Right. Thank you so much, Wallace. Thank you, Masinde. Thank you, Miriam. I'm sorry that the time ran short. We all of you and your departments a whole day. So thank you for sharing with us. As you can see, we are a team. We're actually working together to take care of this spinal cord injury patient from the moment they are injured up to the point we're taking them back to the community. And as you can see, the needs in the community do not end. So we have these 2 days. I hope you'll be able to join us. We have, we have marked the Spinal Cord Injury Awareness Day, which is today. In September, we have the Spinal Cord Injury Awareness Month. On the 5th of September, we are marking the Spinal Cord Injury Day, not awareness, but the day. And the theme this year is to end violence and protect the spinal cord. As we've noted, a lot of our spinal cord injury is related to trauma. Unfortunately, a lot is still attributed to violence. So join us as our stakeholders, join us as our friends, visit the hospital, reach us on our social media handles. I think I have a slide with our social media platforms so that we can work together. These are Kenyans. It's us, it's you, it's me, it's our friends, our brothers, our sisters. Let's come together and support those with spinal cord injury. And as the title says, let's achieve the sustainable development goals by taking care of those who have spinal cord injury, those with disabilities, and just generally anyone who has a healthcare need. So I am so sorry. We seem to have run out of time. What we did is we really tried to answer as much as possible the questions directly. What we weren't able to address satisfactorily, please reach us on those our communication platforms at the National Spinal Injury Referral Hospital. As I mentioned, our team is on the poster. So is the team from KNH. I think KNH is more better known, so their platforms are there. So reach out and join us in September as we discuss more. So Nelson and the team from KNH, is there anything maybe you wanted to say? And I also will appreciate, before I hand over to Nelson, the team at KNH, Collie, Manyara, Mikey, Elijah, Evans, I hope I've not forgotten anyone. And anyone who supported you in coming up with those slides, thank you so much. You've highlighted an area that a lot of us don't talk much about. Thank you, and we look forward to working with you. Maybe Nelson, if there are any housekeeping needs you would like to address to us?
Nothing for now. Mine is just to appreciate you and thank you, and also to welcome you on this platform for more sessions like this so that we can cover more. I can see the questions were a lot. And I think we should do a couple of more sessions before September in preparation for the Spinal Cord Injury Awareness Month. Thank you.
I think so too, Nelson. So we'll reach out and we will let you know as our audience when that is. And please join us again, bring in more friends so that we can pass the word around to as many as possible. So apologies once again, we weren't able to answer the questions live, but I hope we've done justice, and you can reach us and the team at Kenyatta through our various communication platforms. I'd like to wish you all a pleasant afternoon, and let's take care of each other and keep safe. Thank you very much.